Okay, so today we'll be working out pediatric neurology. Go ahead and share my screen with you, and we will open up this PowerPoint. All right, so pediatric neurology. Clinician hears and sees effects of disease and uses power of reasoning to ID biological cause. So when we're talking about pediatric neurology, neurology in all of its greatness basically is here to identify deficits and then try to find where that neuro deficit lies and then see if there's a treatment for that. In the case of kids, we can note these neuro deficits simply by watching the child play, interact with others in the world around them. So as we're gathering the history for neurology, it's no different than any other history. The history really is an interrogation and not an interview. We've got a certain criteria of things that we need to go through, and we need to make sure that we stay on track. We also want to listen to our patients. As many times in the clinical world, I've seen myself make mistakes if I don't listen to people, and often other people will come to appointments and it's pretty easy to pinpoint what's going on if we're able to actually really listen to them and support their needs. Utilizing your history mnemonics here, you can use old carts or OPQRST, whatever you prefer. We want to understand basically where the patient, or in this case, maybe the parent, is coming from, what concerns they may have, what they're going to need. The work note I put here because, traditionally coming from an emergency room background, sometimes you just sit there and wonder, what's the patient really here for? And then as you're leaving the room, they ask for their work note. And then that all kind of brings it together. And it's like, oh, they're actually just here for a work note. So at any rate, we want to keep it problem focused. If it's a new patient, particularly a pediatric patient, we need to get the birth history, as well as comprehensive health history, what chronic problems they may have and what medications they take. A lot of times with patients, I'll say just quickly, got any health problems? Nope. Take any medications? Yeah, I take metformin and, hydrochlorothiazide. It's like, okay, so you have diabetes and hypertension. So those are some things that we just want to ask, and maybe ask them in a different way to kind of get a scope on what's going on. So problem focus history, what's different with kids? Well, with kids, we need to make sure that we're identifying these abnormalities early on because the brain is still developing. So we have a chance on catching these things quickly and making adjustments so that the patient has a better outcome. Cultural, right? So there's all these differences in cultural abnormalities, cultural norms, and cultural mores that we may want to take into consideration when working with different cultures and with the pediatric population in mind. We want to document who gives us the history, whether we're obtaining the history from grandma, grandpa, the mother or the father, one of the siblings, or the child themselves. And then we're going to get into that investigation mode to try to investigate this abnormality. You can use the OPQRST. We want to know if there's any associated neurologic symptoms like headache, syncope, or seizure also. Those are important things to think about. Milestones are always really important when we're talking about pediatrics, as the milestones go basically stone by stone. So if they miss a milestone, that's a problem, right? Because these are basically chronologic. They're going from one to the next to the next. The loss of milestone is never normal. There is a lot of variability maybe when they get to that milestone. If they're actually losing a milestone or are missing one, we really need to get on that and make sure that we fully assess the loss of that milestone. We also want to take into consideration physical, social, environmental, and disease states, knowing that all these, the physical, the social, and the environment, going to impact the child's development. We also want to think about that particular disease states can also affect development. And then basically the way that the H&P is designed is always going to correlate with the developmental level of the child, or even the developmental level and education level of the parent, right? We'll talk to certain people differently if they have more of a breadth of knowledge. And then other persons, we're not going to withhold information. We just may describe our information in a different way, maybe more in layman's terms, so that that proper education level is met for those people so that they can understand just what we're talking about. So here's just kind of that idea of those milestones. So milestones are used to assess development. When one milestone is reached, then they go to the next and so on. Loss of a milestone is cause for investigation. So we really talked about that, but I just wanted to kind of go over a little bit. This here is something that I want each of you to read through. However, I do not want you to memorize it, right? So this is just talking about gross motor, fine motor, speech, and then social skills at these particular ages. And so it's interesting to look at these and then, you know, try to formulate where the child that we're working with is at. And they might fall, you know, kind of above and below, but like the milestone kind of way of thinking, we want to make sure that they're not missing any of these milestones. So what's the verbiage here? So neonatal period is 0 to 28 days. Postnatal period is from 29 days to 1 year. As we assess the newborn, we want to make sure that we're doing the assessment of a newborn. If this is the full assessment, you know, parents are present, we're going to undress the child as much as needed and then swaddle them with a blanket. Dim the lights, particularly if you're doing the red reflex testing. And then if you're able to do some observation of the child's feeding. The newborn exam is really just like a full physical exam for anybody else. In particular, we want to check out the head and neck, heart and lungs, abdomen, and gynecologic parts, as well as the lower extremities, back, ears, mouth, eyes, skin, neurologic assessment, and the hips. When we're assessing a newborn, we're going to do a very brief APGAR score at 1 and then again at 5 minutes. And then the second full physical exam is done within about 24 hours of birth. And then obviously they're going to have exams thereafter at regular intervals. So Virginia APGAR was an anesthesiologist who created this APGAR scale. She was, I think, a nurse anesthetist and was asked by one of her nursing students one time, you know, how do I know if a child is healthy? And so she started to explain it and then realized that there was really no model that we were using that was creating basically like a standardization. And so she came up with this. She said, well, you know, they should be moving around and they should have a pulse over 100 and they should, you know, grimace when we prompt them for stimulation, and their appearance should be pink and they should be crying. Well, so then she put this into this APGAR scale. And so we use this APGAR scale at 1 minute and then again at 5 minutes to assess these children. And so that we have some data points to say, this is a healthy baby, this is not a healthy baby, we're worried about this baby, we're not worried about this baby. So the APGAR score is used to rapidly assess newborns. It gives us the standardized protocol to do so. The APGAR is performed at 1 minute and then again at 5 minutes. Once the APGAR is greater than 8, then we can conduct a full physical exam, which is usually done the following morning. So getting away from the newborn assessment, now we're getting into headaches, which you're probably going to be seeing these on your adolescent pediatric patient. But at any rate, we need to learn this. So a primary headache is considered a tension headache and migraine headache. A secondary headache can be caused from minor illness or a serious condition, such as a CNS tumor or a brain abscess. The nighttime awakening is this history that we get when we're concerned about either a CNS tumor or a brain abscess. So there's definitely some things we want to discern with the headache. We want to know really where the headache is at. Can you describe it for me? When does it come on? What kind of things help it? And so we can use our old carts to kind of dissect the headache and to figure out if the headache is concerning to us or not. So there's this pound criteria that we use when we're assessing for a migraine headache, or we're just trying to figure out, well, is this a migraine or is it a tension headache? What kind of headache am I dealing with here? So the pound criteria is just a mnemonic that we use to assess if it is possibly a migraine or not. So a migraine is generally pulsatile. It has a duration from 40 to 72 hours. It's usually unilateral. It's associated with nausea and can be extremely disabling for the patient. So they got to go in a quiet room. They can't be exposed to a lot of noise, all those kind of things. So if you're going to call it a migraine, then you want to either say if it's a classic migraine or a common migraine. A classic migraine is associated with aura. So some aura that precedes the migraine, like you can feel it coming. Maybe it's a smell or it's a sensation, but somehow there's this aura. A common migraine, which is about 80% of migraines, does not come with an aura. It's just this pulsatile, unilateral, debilitating, long-lasting headache. The treatment for both a tension headache and a migraine headache is ibuprofen. Needs to be one of the first things that we try. It's usually very effective against headaches. Also, since headaches are primarily caused by dehydration, particularly in this CSF, we want to hydrate these people. This is what we're doing a lot when people come in with a headache to the emergency department. We're giving them fluid resuscitation and then the NSAID medication as well, and they usually resolve very well. So the starting treatment for children is ibuprofen, a couple glasses of water, and to rest in a quiet room. This is a little diagram that shows you different headache locations and kind of names for headaches, but your migraine you see is this unilateral, tension headaches kind of all throughout, band around the head, sinus headaches basically in the sinuses. Cluster headache is going to be on one side behind the eye, and it will be associated with lacrimation, so we'll talk about that a little bit. Allergic headache is kind of close to like a sinus headache, and then an exertional headache can occur anywhere and is worse with exertion. So a cluster headache is this kind of strange, rapid onset, and they don't last very long, maybe 3 hours max. But the presentation is this severe unilateral periorbital lacrimation and nasal congestion. And if we see that all together, we're really thinking about a cluster headache. If you think about it, the cluster headache really is going to hit this trigeminal nerve. And so basically everything that trigeminal nerve targets can have some abnormalities, and that's why we get the lacrimation and the drainage or congestion in the sinuses. Now this is not truly trigeminal neuralgia because it's an actual bang headache, and it lasts for a short period of time, where trigeminal neuralgia is going to be more chronic in nature, but kind of that same distribution of nerve is affected. The treatment is 100% oxygen. Now, this is both therapeutic and diagnostic. Is you administer 100% oxygen and you see if the patient resolves. Usually it's about 5 minutes for that. So interesting kind of headache there. The Snoop criteria. So the Snoop criteria is designed to help us think about headaches and to evaluate if there's some concerning features to that headache. So it's really just a nice mnemonic that we use to help potentially catch life-threatening headaches. And what the Snoop criteria mnemonic tells us is that we want to look for systemic signs or disorders. We want to look for any neuro deficits. The onset is new or is different than previous headaches and is in a patient greater than 50 years old. The onset is a thunderclap presentation, is associated with either increased intracranial pressure, which would be papilledema, pulsatile tinnitus, so pulsating, ringing in the ear. It's positional, so you bend down to pick something up and wham, or it's precipitated by exercise. So those are really all, these are basically talking about an aneurysm or some sort of vascular cause. And anyway, the Snoop criteria, so new onset. I had a kid that came in to the emergency department, 26-year-old kid, terrible headache, but he had never had headaches before, and the headache started that morning at about 3 a.m. and woke him from sleep. I did a CT scan as I was using this Snoop criteria, and I'll be darned, the kid had a brain tumor and went immediately to Seattle. So something to keep in mind. We see headaches a lot, so it gets easy to be passive with them. However, we need to use this criteria, and we need to really think about those keys that separate normal headache from a concerning headache. So how does a central nervous system tumor present? Well, it's going to present with a gradual onset. And it also, because it's connected to the brain and the rest of the neuro system, it may have some neuro deficits associated. So that's going to be specific for these CNS tumors. Most common CNS tumor is a glioma, and the worst is the glioblastoma multiforme. Here's some of the structures of the brain, right? We've seen these before in anatomy, but you've got your frontal lobe, and we know that that's responsible mostly for decision making, personality, judgment, that kind of thing. So if there's some sort of a tumor in that location, it's going to cause problems here. And so some of these we might not traditionally think of as headache or seizure symptoms, but they'll come up because of the location that they're affecting. So the parietal lobe, right? The way you calculate things, reading and writing, temporal lobe, language, comprehension, pituitary gland might be growth hormone problem, fertility problems. The brain stem is going to be all of those kind of autonomic nervous system things. Cerebellum will cause coordination or fine motor problems, and the visual cortex may cause visual abnormalities. So CNS tumors here, this is just like some symptoms that people had with CNS tumors. So you can see that, 41% was the headache, and then they also would have other things like unsteadiness, vomiting, visual difficulties, behavioral abnormalities, inability to kind of process information, seizures, focal weakness, all that kind of thing. So we want to keep those in mind because they do present on a spectrum here. So here's some of the effects of brain tumors on the body, but you can just see that there's a whole host of effects. And so sometimes we want to just keep this tucked in the back of our mind and keep it somewhere on that differential. So this moves us right into seizure. So seizure defined is a sudden uncontrolled electrical disturbance of the brain. There can be focal seizures, which are considered either simple or complex, and then generalized seizures, which are your absence or absence seizure and the tonic-clonic seizures. Status epilepticus is a seizure that lasts longer than 5 minutes. And then these infantile spasms are basically seizures in infants. But also, we need to be educated to know that these can cause neurodevelopmental difficulties and that we need to make sure that these kids are sent out to a neurologist ASAP as that brain is still developing. So a partial seizure just means that there's no alteration in consciousness. You can have motor symptoms, you can have sensory symptoms, but you're not altered mentally. You remember things, you know what's going on, you're with it. A complex partial seizure means they're altered. So they have an altered level of consciousness. That's the difference. An absence seizure are these staring spells, okay? They stare into space. Teachers kind of sometimes will misconstrue this for inattention, but basically the child is having a seizure where they're seizing, but you can't see anything physically. You just see a blank stare on this child's face, and then they're back. So it really is a loss of cognition, a loss of consciousness there for a while. Treatment is ethosuximide. This is only for absence seizures. Other seizures will respond to other anticonvulsants like valproic acid. Then we have our tonic-clonic seizures. These seizures are the ones where the patient is getting hypertonic, so they're tightening their muscles, and then they're also convulsing, okay? So that's considered tonic-clonic. So these generalized seizures are going to target both hemispheres, and that's really what makes them a generalized seizure. They produce a loss of consciousness, either briefly or for a long period of time, and can be subcategorized into generalized tonic-clonic seizures and also, which is considered a grand mal seizure. So those are the major types. This gentleman was a Disney Channel star, and he died of status epilepticus. He had a seizure at night, and nobody was privy to it, and he died that night by, I think, asphyxiating on his tongue. The patient, this child did have a known seizure disorder and was undergoing treatment. However, they had just recently adjusted his medication, and he ended up dying of a seizure in the night, which is just a terrible tragedy. Moving on to febrile seizures. So a febrile seizure is defined by exclusion. So it cannot be associated with an infection. It cannot be associated with a metabolic abnormality, and it cannot be associated with previous afebrile seizures. So when you say infection, it's not associated with a known infection. A lot of times it can be triggered by a virus that causes the temperature to elevate quickly. However, it's not associated with like a meningitis or a bacterial infection or inflammation of the meninges. It's really just a seizure that occurs when the rate of change of temperature happens quickly enough, which they're not exactly sure how it works, but they think that somehow the sodium channels are disrupted and the child will seize. 30 to 50% will have a reoccurrence risk. So let's talk about these a little bit. The most common neuro disorder in infants and young children is this febrile seizure. anywhere from 6 months to 5 years. These are occurring typically when the temperature is greater than 103, but it really is the rate of rise that causes the seizing. So it is that change. Okay, the quicker the change, the more likely they are to seize. So if they go from 99 to 103 in a fast amount of time, then that's usually when we're going to see these. There's simple and complex, and the verbiage kind of helps you to deduce which ones are more concerning. A simple one is less than 15 minutes and has no reoccurrence within 24 hours. This is by far the majority of these febrile seizures. A complex febrile seizure lasts longer, can be repetitive, and may have an increased risk of developing epilepsy. So we want to lower these children's temperature so that it doesn't occur again, and we want to give them rectal diazepam if the seizure is greater than 5 minutes. So these febrile seizures, we need to be good at them. We also need to be able to rule out other etiologies like electrolyte abnormalities or something like that. The electrolyte abnormalities that these are thought to be, because they are thought to cause some sort of transient cerebral sodium change, these are not going to show up in the peripheral blood. So we want to actually check their peripheral blood and make sure that we don't see any of that. Because if we see that, like a strange potassium or sodium or something like that, it can be a cause of a seizure, but that would not be considered a febrile seizure, as they would be seizing from an electrolyte abnormality. So once we get into the systemic blood, you're not going to see any abnormalities. These are considered very brief transient changes in the brain chemistry. So when we check the peripheral blood, we won't see any change, and if we do, then that's actually going to be probably our cause of seizing. So the bottom line with infants is, why do they seize? Well, because they have a lower seizure threshold, and we think that has to do with sodium abnormalities, but you can read up on it as much as you like. It's still pretty unknown. So we know that it's the change in temperature, and we've also are starting to kind of pinpoint that a lot of these tend to be associated with viral infections. And so some of these have been pinpointed. There is or does appear to be a genetic link, as these are more common to occur in parents of children, or in the children of parents that have had these. So there's thought to be a genetic link. So how do we diagnose a seizure? Well, the seizure is largely diagnosed all right. So back at it. So diagnosing a seizure. So diagnosing a seizure really is from the observer of the seizure. We've got to get this history. You can also get some of the history from the patient themselves, but usually we want to know what happened at the beginning, the middle, and the end of that seizure, what time of day it occurred, the age of the person, and potential triggers. Okay, so the history, was there any incontinence or tongue biting? What is the frequency of the seizures? When do they occur, like time of day? How long do they last? And then history of medication and then compliance to medication. So that's kind of what you want to do with seizures. Also, the workup for seizures, we need to rule out any metabolic abnormalities, do an EKG. We also need to do a CT of their head, and any a urine to check for any drugs of abuse. So here we're looking at these breath holding spells. So a breath holding spell is an autonomic reflux. So you kind of think of these bratty kids that throw a fit and hold their breath till they pass out. That's not really what's happening here. It's actually a reflex. Although this does look like a bratty kid throwing a fit on the floor, these kids pass out and it's considered an involuntary reflex. The good thing is they usually grow out of it by about age 6. So it's associated with genetics. There's been family links as well as with iron deficiency anemia. So that's really interesting. There's a few different types. There's a cyanotic type where they basically hold their breath until they pass out. They turn blue, obviously. And then a pallid state, which is actually where they have this stressful event and then their heart rate slows and the bradycardia then causes them to pass out. So at any rate, it's an autosomal dominant trait. So we do see it in families. And you just need to be aware that these are something that can occur normally and that we need to rule out other etiologies before we want to call this a breath holding spell, which is really just kind of a diagnosis of exclusion. So vasovagal syncope is kind of the adult form of these. It's a little bit different, but is considered a neural reflex as well. Basically, the patient is exposed to some sort of stressor, emotion, quick change in position, pain, fear, heat, blood, physical activity, and then they pass out. It's called the common fate. Usually lasts for a couple minutes max before they come back. These are usually diagnosed in young, healthy people. It is also a diagnosis of exclusion, so we need to exclude more insidious causes of syncope, and then we can start to assume that maybe it was just a vasovagal syncope. So classic, there's some sort of emotion. I just took a hot shower, I was sitting on the side of the tub, and then I got up and wham, fell. Exposure to fear or pain, something like that. Would be atypical if it's an older patient and it's recurrent. So then we really want to think about other causes. So syncope, there's different types of syncope: reflex syncope, cardiac syncope, and neurocardiogenic syncope. So those would be some of the types, and then the causes are either a sudden drop in blood pressure, can be a benign condition like vasovagal syncope, serious medical problems, and then drastic hormone fluctuations can also cause it. Can range from lightheaded to falling with no reason, vision change, or blackout. The treatment usually is going to be trying to exclude the underlying cause. We want to make sure that their medications are appropriate and that we've excluded any other cause of syncope. Guillain-Barre. So Guillain-Barre is considered an acute monophasic paralysis. So when you break that down, it basically says paralysis starts at the feet and works itself up. So it's provoked by an illness, particularly after a GI infection. It's an immune-mediated polyneuropathy, and it triggers this immune response that degrades the myelin sheath, causing difficulty in sending proper electric signals. And then these are the symptoms you can get. So diarrhea, muscle weakness, and it is an ascending paralysis that occurs from the breakdown of myelin. It's really common with Campylobacter jejuni infection. So it's this ascending paralysis, progressive weakness, can definitely affect the respiratory system if it gets that far. And then this bulbar weakness can actually occur before it reaches the face and neck area, but this is caused by cranial nerve problems And you're going to see anything with the bulbar weakness is going to cause speech abnormalities or vision changes, some difficulty with voice quality. So here's how it works. Basically, these autoantibodies attack the myelin sheath. Myelin sheath is this nice coating around the electrical circuit. And when that coating is disrupted, then the electricity kind of goes all over the place and has inappropriate action. So here is this Guillain-Barre, just nice little one page that explains it all. So Guillain-Barre, most commonly after Campylobacter jejuni infection, it's going to affect the feet and work up. It's symmetrical, okay? So that's a really big point with Guillain-Barre is that it's symmetrical, okay? So there's some things here. Symmetrical, Campylobacter, right? Ascending paralysis. That's the biggest one, right? Decreased deep tendon reactions. And then the treatment is plasma exchange. So we want to take all those nasty antibodies out and we want to exchange them, basically centrifuge them out and replace the rest of the good stuff. Moving on to transient juvenile myasthenia gravis. So if it's myasthenia gravis and it can affect a juvenile, it's a rare form of myasthenia gravis where the autoimmune disorder targets a child and can cause all these problems. A lot of the times we see this on the eye, but the history is going to be this progressive weakness throughout the day. It's antibody mediated and T cell dependent. And you get this progressive weakness daily. So like during the morning, they feel fine. And then throughout the day, they get more and more and more and more weak. So we want to establish that the patient has signs and symptoms associated with myasthenia gravis. We can try the ice pack test, and that is confirmatory, but does have some limitations. Also, the serology for ACH receptor antibodies. Or we can do electrophysiology with like an EMG or a muscle study. And then we want to rule out thymoma with a CT chest or MRI chest imaging. There's a strong link between thymoma and myasthenia gravis. 30 to 40% of people with myasthenia gravis will have a thymoma, and those who don't, 30 to 40% will develop a thymoma. So they're thinking that this is, remember, T cell mediated. So the T cells are born in the thymus. So they're thinking there's definitely a link there. So this is the ice pack test, right? So here this guy has his droopy eyelid. What you do is you have them kind of open and close, open and close, open and close, and that will fatigue out these muscles of the eye. And then they place the ice pack on there, and then the eye is more open now and not as fatigued. I wanted to figure out exactly how this test worked, but as I researched more and more, nobody really knows. They think that maybe cooling the eye may have some effect on the metabolism of ACH, and so that's why maybe the ACH slows down the enzymes that break down ACH, and then therefore, and that's just all really theoretical, but they're thinking that maybe the coolness slows down the enzymes that break down ACH, which makes sense. So neonatal myasthenia gravis, this is just a very terrible thing, right? But basically what happens is the mother has myasthenia gravis. She then transfers antibodies to the fetus via transplacental transfer, and then the fetus, when born, has difficulty breathing and all these other problems. But we need to treat this child with cholinesterase inhibitors for several weeks. And they will normally completely be normal. So they might not actually have myasthenia gravis. They don't have a thymoma, but their mother did. And so once we inhibit these cholinesterase enzymes, then we will be able to get this kid breathing better and have his muscles work a lot better. So it's transient. It's only going to last for until we treat for a few weeks, and the child really has a good prognosis after that. So talking about pediatric head trauma, so we've got concussion, post-concussion syndrome, and traumatic brain injury. So a concussion, right? So it's basically a bruised brain, right? You get hit hard enough, the brain has some sort of trauma to it. It disrupts electrical flow. The brain needs to heal. When we are assessing for concussion, we want to think about the mechanism. What was the height of the fall? What substance did they strike? Did you hit the grass or did you hit the concrete? What was the location? Did you hit the front of the head? Did you hit the back of the head? Was there any loss of consciousness? Is there a scalp laceration? And was there any alterations in behavior following the trauma? Repeated injuries, we want to know about those. The most common prognosis is really no complications. However, if they've had multiple injuries and multiple concussions, then they're more likely to have devastating neurologic defects like extreme depression. Junior Seau ended up committing suicide, and they think that a lot of that was from repeat concussions. Muhammad Ali ended up with Parkinson's syndrome, and there's some thought that that may have been linked to a recurrent concussion. They can have permanent mood and behavior changes and repetitive injuries in these individuals. We see a lot. Also remember location, right? So if the concussion is in the frontal lobe more often, then they can have a difficulty with those type of functions, right? So their personality, they can have difficulty with impulse control and things like that based on the location of the injury. So PACARN is this rule that we use. It's basically a rule to help us not irradiate more children than we have to, or adults. And so this is the CT rule. So if a child is under the age of 2 and has any one of the following, which is a GCS under 14, altered mental status, or a skull fracture, we need to CT these kids because there's almost a 4.5% chance that they could have a traumatic brain injury. Then we got this other rule that says, okay, well, 1 or more, right? So I'm guessing that that's 2. It's interesting because it's like 1 or more. So I guess it means if there's 1, you image them, and if there's more, then you, 1 or more. Yeah, so it's very interesting how that's written. We'll let's look later too to confirm that. So anyway, here, so we've got a non-frontal scalp hematoma, right? Not in the forehead. Forehead doesn't count, okay? Loss of consciousness for greater than 5 seconds. Severe injury mechanism. So they're like, driving a 4-wheeler at 30 miles an hour and strike a tree, right? That's a severe mechanism. Pedestrian or bicyclist without a helmet struck by motorized vehicle. Fall of greater than 3 feet. Head struck by a high impact object like another vehicle, a piece of concrete, something like that. Abnormal activity per parents. Then we consider a non-contrast CT or observe. So that would say one of these or more. So if one of these is here, we have the chance to do the non-con, or we can talk about observation with the parents. So then as you get older, the criteria changes again from 2 to 18 plus. Any one of the following, so GCS again, equal to or less than 14, altered mental status, signs of basilar skull fracture, then we obtain the CT. 1 or more of the following, so vomiting. See, vomiting wasn't in the last one. Loss of consciousness, severe mechanism, severe headache, then we will consider or we can observe. So those are really nice criteria to kind of have down. As the nice part about these criteria is as long as you're following them and you're using them, even if you have a bad outcome, but you followed the criteria and you clearly documented it, at least you have this as the backup to say, hey, look, I was following this criteria. I'm trying to limit CT scans on people that don't need them. So here's just this, California has this little thing here, but this is just a little algorithm that gets you through it. So what's a facial nerve palsy? So facial nerve palsy is common in kids, particularly after birth due to trauma. A facial nerve palsy is which cranial nerve? Cranial nerve 7. Okay, so cranial nerve 7 is really interesting because obviously you have this trigeminal distribution, okay? It's the facial nerve, right? So if the facial nerve is involved, then you will not get any furrowing of this forehead. You can see this is the side that's affected. The patient is unable to furrow their forehead, whereas this patient, this side, no problem, okay? So when we see this, we know that it is truly a Bell's or a paralysis of the facial nerve, and it is not a stroke, okay? In older individuals, we want to be careful because if the forehead is spared, then that's actually more concerning, because if they're able to furrow their forehead but not using any of these, we're highly concerned for a stroke. So originates in the brain stem, this cranial nerve, facial muscles, and forehead are affected. Most common pediatric problem with this nerve would be Lyme disease, also otitis media, mumps, and parotitis. So you can imagine that swelling around this area is going to put pressure onto this nerve and can cause that as well. There's a 3-fold increase in pregnancy, and we would want to think about what are we going to do for imaging and what are we going to do for, in this case, it's probably going to be an EMG, because we want to make sure what's really going on with this neurologic function. Treatment is generally antivirals and or steroids to decrease inflammation that's probably causing irritation to that nerve. So here's just a diagram of the cranial nerves. So cranial nerve 7, right? And then we've got your trigeminal nerve here. So a true Bell's is going to be a cranial nerve 7, and then facial nerve paralysis is cranial nerve 5. So Tourette's disorder. So what is Tourette's? It's basically this disorder that has the hallmark of these tics, and it's really kind of a sad disorder, as there's a lot of emotional factors and can be very complicated, especially socially, for these children. So it's considered a disorder of the mesolimbic circuit, or the corticostriatal thalamic cortical circuit, which is just a whole bunch of words to say. But basically what happens is these kids have these tics, or this basically like an itch that needs to be scratched. And so they make these movements or repetitive noises. It's strongly associated with ADHD and strongly also associated with obsessive compulsive disorder. So they're wondering, is this a compulsion? Is there actually something going on in the brain? But at any rate, there can be structural and metabolic abnormalities. So we need to basically make sure that we rule those things out. And there's this biennial transmission. So both parents have it, and the child is more likely. It's a higher rate in males to females. Medication options that help for both the tics and ADHD include these alpha adrenergic agonists, and then clonidine is another option. So Tourette disorder, this is just kind of a flower that shows you how many different things go into a Tourette syndrome. Cerebral palsy. So cerebral palsy is is a disorder that basically occurs when there's some sort of brain trauma at birth, and it is a non-progressive abnormality. Okay, so with CP, we're not going to see any progression. Basically, it is what it is. That doesn't mean that there's no treatment for it or that we can't improve their quality of life, but it's not progressive and it is not going to go away. It is a permanent disorder. due to some abnormality or injury hit the brain during development. So here you go, non-progressive permanent disorder, and it affects tone, posture, movement, and intellectual, can cause intellectual disability, alterations in sensation and perception, and can make them more prone to seizure activity. Serum creatinine may be elevated in these individuals as there may be some muscle breakdown, especially as they start to develop. So microcephaly, we can see this with CP. You can see this with brain injuries. It's also seen with a common virus transmitted by a mosquito, which is, I think it's the Aedes aegypti mosquito, but we'll look farther. But that's the Zika virus, right? So Zika has been one of these viruses that causes this microcephaly. And you get this severe microcephaly, and basically the brain's not as big as it needs to be. So what regions are affected, we'll also look at that. So here's the 2020 map of anybody that's even reported a Zika case. So it's really spreading. Before 2020, it was really up to this kind of North America or United States and Mexico line here. But now we're even seeing it in the United States. And part of that is because the Aedes aegypti mosquito, the climate is warming and they're able to get up more northern. That's the thought. So you've got this Aedes aegypti, which is your Zika carrier, and then also the Aedes albopictus is another cause too. So back to CP, there's going to be pain associated with it, especially because they've got this tonicity in their legs and these spastic type of manifestations. They can have intellectual disability, speech and language disorders, bladder problems, visual problems, epilepsy, behavior disorder, hip displacement, sleep disorders, drooling, hearing impairment, gastrostomy tube dependence. So just a lot of problems, you know, that those muscles are not functioning properly. Infant botulism, this is another neurologic problem that we want to be aware of for infants. This is also why we do not give infants under the age of 1 honey, as botulism has been found in these food sources, and so we try to keep those away from infants under the age of 1. So infantile botulism, basically they eaten something that's contaminated with Clostridium botulinum, which is a gram-positive rod-shaped spore-forming anaerobic bacteria that basically is everywhere. It lives in the soil. But botulism is particularly heat resistant and can survive atmospheric pressure increases up to 5 atmospheres. Oh no, sorry, up to 1 atmosphere for 5 or more hours. So botulism is different. It's going to cause a descending paralysis. So this is something we want to jump on right away. And it can cause dilated pupils as the pupil is not able to accommodate, and dry mouth. So basically the botulism neurotoxin enters the bloodstream, releases into the circulatory system, causes problems at the neuromuscular junction, blocks synaptic fusion of ACH, or the release of ACH, however, and then causes this flaccid paralysis. So let's look at this. So basically you've got these neurons here with cytoplasmic acetylcholine in those vesicles. The botulism exotoxin causes those to not be able to be released. And so these ACTH vesicles can never cross the synaptic cleft and activate the motor neuron. And so then you get this flaccid paralysis. So muscular dystrophies. So we're going to talk about Duchenne and Becker muscular dystrophies. The muscular dystrophies are an inherited group of progressive myopathies resulting in defects of a number of genes required for normal muscle function, right? That's basically, you've got this progressive myopathy, right? That's the key term there, progressive myopathy. So that's with Duchenne's and Becker. They're progressive and they're really traumatic because these kids look normal, and then about 3 years old, you start noticing these problems. So Duchenne's and Becker, we'll kind of use them interchangeably here, but they're basically a problem in dystrophin. So what dystrophin does is it helps the muscle cells. It's a structural component for muscle cells. The exterior of the muscle cells anchors to the cytoskeleton using dystrophin, and so they have an abnormality in the function of dystrophin, and that causes problems with the muscle cells. And then the muscles are repeatedly damaged as they contract and relax, and then you get this problem with the muscle. So it's this progressive weakness at the onset of 2 to 3 years of age, and that's the Duchenne and Becker muscular dystrophies. So here's some like a netter drawing on this. So you can see just how contorted this poor kid is, and this is kind of the development. So at 2 years, minimal or no symptoms, and then by the age 15, I mean, the kid's in a wheelchair. So it's just terrible. But the inheritance pattern is mostly what is probably the take home here. Besides it being progressive, you also want to know the inheritance. So moms are normally the carriers, and you don't see it expressed in females. They're just the carrier. So it's sex linked. So it's on the X chromosome. So mom's going to give her X, dad's going to give the Y. And so if mom's X is a carrier and dad's Y, now since this is a son, right, this child is going to be fully expressing this genetic makeup. Whereas a female, if she's a carrier, she gets that from mom, she gets that from dad, and she's a silent carrier. So that's the difference. This is the Gower sign. So this is a sign that they came up with, a smart guy Gower, right? Where to help kind of give themselves a little more oomph to stand up, they may push on their legs like this as they don't have the strength to stand their whole body up. So that's called the Gower sign. So here's the inheritance pattern, which we talked about. So here's carrier mom's X chromosome. She passes that chromosome to all 4 of her children. However, sorry.
A patient is here for a release letter, but he was detected with coronavirus. So he at least needs them to know that he can't go back to work right now.
Okay.
Thank you. Welcome. So on this part, the following dates, we'll just put until negative, or what would we put?
I mean, it depends what his employer wants. All right, so we're back at it here. We are recording, yes, and let's do. Share my screen. Oh, I am sharing. Okay, I'm current side. Okay. So the inheritance pattern, we'll get back here. Sorry about that. So mom's the carrier with this is her carrier chromosome, which I wish they would write that on there. I think that's helpful. So, okay, so mom's a carrier. Here's her X carrier, okay? And she passes an X carrier to the daughter. but the husband passes the normal X. And so she's just going to be a silent carrier. Okay. This daughter got an X that's not the carrier, right? She got this one from mom and normal from dad. But this guy, he's in trouble because he's got the carrier and nothing to. So remember when they go, what is that? Prophase? Oh my gosh, I'm going way back. So if you've got two X chromosomes, when they're in prophase, they're going to cross over and they're going to exchange genetic material. So this, the fact that the child has a Y means that he doesn't have anything to cross over with. He doesn't have anything to mask this with. So he's going to fully express this genetic trait, which is a super bummer. All right. So let's go on to meningitis and we'll finish off with this happy topic. But meningitis basically is inflammation of the meninges, and you have different types of it. Some of the effects of meningitis include fever, obviously photophobia, stiff neck, stiff back, and then this petechial rash caused by exotoxin production, which causes you to have leaky capillaries and to leak blood into these spaces, causing a petechial rash. So the presentation is going to be, you know, these people are sick as stink, right? They're going to be super sick. They're going to have a fever. They're going to have a headache. They're going to have a stiff neck. They're going to have abnormal bleeding or bruising. And that's going to be the inflammation of the meninges is going to cause pain, right? And so anytime we put pressure on that meningeal cavity, we're going to cause discomfort. And that's where these Koenig and Brudinsky sign come in. The Koenig sign stands for knee flexion with the knee, and the Brudinsky's is B for bend the neck. So Koenig sign, basically, knee flexion causes them to have pain in their neck, or they'll raise their neck to try and decrease the tension on the meninges. And then the Brudinsky sign is where they bend their neck, and secondary to you raising the leg straight. So it's a straight leg raise. The etiology is that neonates usually are going to end up with this E. coli infection or beta strep group B from coming through the birth canal, being exposed to the mother's flora or some pathogens there. And then most common in adults is going to be the Neisseria meningitidis or strep pneumo. And immunocompromised, we're looking at your fungal infections, which is Cryptococcus neoformans, and that is diagnosed with the India ink stain. So meningococcus or meningitis, meningeal inflammation or septicemia is going to have these petechial rash, and it's basically caused by the toxins in the bloodstream, allowing the blood to disseminate through the capillary beds. So there's bacteria in the bloodstream. They're going to have this severe headache. They're going to be sick as stink, right? They may be sleepy or turning away from light, breathing fast. There's going to be all these kinds of signs of infection. So what we have to do is a spinal tap. This is the band Spinal Tap. I thought that was funny. But anyway, a spinal tap is through L3-4. We want to find that space, right? We've got our vertebral column, right? And we basically want to do a spinal tap in between the vertebrae, and we're trying to get basically into that space and pull some fluid out to see if that fluid is infected. So these are the findings associated with a meningitis. You're going to have an increased opening pressure. The opening pressure is basically just this, we've got the needle coming out and it's got this sheath here, and we put this tool that measures pressure. So if the pressure is increased, the reason for that increase is there's a whole bunch of schmutz in the spinal fluid that's causing the increase of pressure. So it could be gas that's formed by the bacteria or extra proteins, but at any rate, you've got an increased opening pressure. That's a bad sign. Also decreased glucose, because that bacterial infection is going to be gobbling up all the glucose for energy, and it's going to decrease the glucose in the CSF. Increased white blood cells, fairly self-explanatory. The body's trying to fight that infection. Primarily, you're going to see neutrophils if we're dealing with a bacterial infection. And then increased protein, because there's just more stuff in there. And when we're seeing the protein, we're probably just seeing genetic material from the bacterial infection. Also could be seen with a viral infection too, because you're going to have more stuff. All right, treatment is dexamethasone and empiric antibiotics. The dexamethasone is given to prevent hearing loss secondary to Haemophilus influenza infection. So we're going to give them empiric antibiotics, which are cephalosporins, vancomycin, penicillins, which are going to cover for your common E. coli and beta strep group B species when we're talking about little guys, little infants. So here's some of the different lab values that we're going to get back. This is a normal spinal fluid, and it's going to have an opening pressure of 5 to 20 with an appearance that's normal, which basically means clear, completely clear. There's going to be low to normal protein, and then this glucose, look, it's 2.5 to 3.5. That's normal for normal spinal fluid. And then the gram stain is going to show us nothing with a glucose to CSF ratio of 0.6. And this is the white cells, so there should be less than 3 white cells if it's a good tap. In a bacterial infection, you're going to see an increased opening pressure as the bacteria are producing gas, which are increasing the opening pressure. The appearance is going to be turbid, which means that you can't easily see through it. With protein greater than 1 gram per liter, a decreased glucose because the bacteria in here are gobbling up all the glucose for energy. Gram stain is going to be positive almost always, 60 to 90%. And then we're going to see a decreased glucose to CSF serum ratio. So you're taking the glucose in the CSF and the glucose in the serum, and you're making this ratio. And then greater than 500 white blood cells per cubic milliliter, and then greater than 90% neutrophils. In a viral infection, you're going to see, I think really the take home here is that your gram stain is normal, and that that the opening pressure is kind of normal. I mean, these are not great, right? It's clear, okay? And the gram stain is normal. Those are the two things that say, oh, this is a viral meningitis, or what they call an aseptic meningitis. And then with fungal, you're definitely going to have some predisposing feature to really consider this. The patient, if I've got an HIV patient with a stiff neck and signs of meningitis, then I'm concerned that there's a possibility for a fungal pneumonia or meningitis. Aseptic, basically caused by a virus or a fungus. You're going to have a normal opening pressure and increased white blood cells, but they're not going to be neutrophils. You're going to symptomatically treat them. You're going to have a negative gram stain too. Aseptic meningitis is not caused by bacteria. So this is kind of encompassing term that they use, and they say, okay, well, it's aseptic. Well, it's still terrible, but it's not caused by a bacteria that we isolated. And viruses are the most common cause of aseptic meningitis, also known as viral meningitis. So aseptic meningitis is common cause of encephalitis. Encephalitis can be caused also by other viruses like herpes simplex virus, common in immunocompromised persons. And they can also suffer from cytomegalovirus. So the signs and symptoms are going to be altered mental status, seizures, personality changes, clinically different due to altered brain function. The diagnosis is PCR for the viral. So a lot of times when we're doing a spinal tap, we'll also send off for PCR culture or PCR, I guess it's not a culture, but Plymouth chain reaction to see which viruses are in there. And then the treatment is to treat for the symptomatic. If it is HSV, then you'd be thinking of more of your antivirals. Facts about encephalitis. So it's inflammation of the brain caused by the immune system can attack the brain as well. Anyone can be affected by encephalitis, irrespective of age, gender, or ethnicity. The death rate is high, and survivors are left with prior acquired brain injuries. It's more common in many countries than motor neuron deficits like multiple sclerosis, bacterial meningitis, or cerebral palsy. So those are just some interesting fun facts. And that is it for pediatric neurology.